Welcome, everyone. So I want to wish you all a good afternoon. My name is Beth Stewart. I'm the Executive Director for the Texas Oral Health Coalition. And on behalf of the coalition, I want to welcome you all to our first quarterly member meeting. We are pleased to launch this 90-minute quarterly event with an incredible one-hour presentation today by Rear Admiral Timothy Ricks. So without further delay, I'm pleased to introduce our esteemed speaker, Rear Admiral Dr. Timothy L. Ricks, who currently serves as the 20th Chief Dental Officer of the U.S. Public Health Service, as well as Assistant Surgeon General. He serves as the Surgeon General spokesperson on oral health and interacts with Chief Dental Officers from other countries, with military Chief Dental Officers, with leaders in organized dentistry, with state oral health programs, and much more. Rear Admiral Ricks has served in the U.S. Public Health Service for over 21 years. Prior to this service, he was an associate dentist, independent contractor, and sole proprietor, and he also served as a military police officer in the Army National Guard. In addition to his role as United States Public Health Service Chief Dental Officer, he also serves in various roles in the Indian Health Service, including Continuing Dental Education Coordinator, Expanded Function Dental Assistant Coordinator, IHS National Oral Health Surveillance Coordinator, and National Oral Health Promotion Disease Prevention Coordinator. I think he's got plenty on his plate to do. So it is with extreme pleasure that I give you Rear Admiral Ricks.
Wonderful. Thank you, Ms. Stewart. And can you see my screen? All right. Wonderful. Well, it's an honor to be with all of you today. I do have some Texas connections. Just to start off with, my late father and my stepmother lived in Wimberley, Texas, which is between Austin and San Antonio in the Hill Country. And I've been to the Hill Country many, many times. I love that area, San Marcos, New Braunfels, and so forth. So, and I have been down to the Indian Health Service Clinic that's in El Paso. I saw some people from El Paso as well. So I just want to start by telling you that this is a great opportunity for us to come together. I applaud your state for having a state oral health coalition. Not every state has a robust oral health coalition, and I'll talk about that in a minute. I always like to start with this slide because we've been talking a lot lately about integration of oral health and overall health, and it's not just medical dental integration. So I just want to, if you get nothing else, get this from the title slide today, that when we talk about integrating health, we're all healthcare professionals first and foremost, and oral healthcare professionals second. So we're talking about integrating oral health into medical care, but we're also talking about integrating medical care into oral health. And I'll give you some basis for that in a few minutes, but also behavioral health into oral health and so forth. My obligatory disclosure statement: I have nothing to disclose. I'm a federal employee. I have no conflicts of interest to speak of. I will say, since Ms. Stewart brought up adult dental benefits, that I am unable as a federal employee to comment on pending legislation of any type. So all I can do is provide fact-based information. So when it comes to the Q&A, if you ask me about a Medicare dental benefit, I will politely decline to give you my personal opinion on that. What we're going to talk about are, I'll go over coalitions just briefly. I always like to tell you a little bit about the U.S. Public Health Service, so I'll do that. And then we'll talk about at a national level, oral health inequities and disparities, and what's an inequity versus the disparity. We'll talk about access to dental care across the country, some workforce drivers of inequity, And then I'll close out with where I started, and that is integrated care. So you are my 19th state oral health program that I've visited. And of course, in the last year, most of the visits have been virtual. But I have been Chief Dental Officer since late 2018. It's a 4-year term appointment that crosses over different surgeons general. So my term actually expires late next year. And this picture on the right is from Kansas back in 2019, one of their Oral Health Coalition meetings. I am glad to be here with you today. I wish it were in person, and maybe in the future it will be in person. But like I said, let me start a little bit with a background of the U.S. Public Health Service. Our motto is in officio salutis. So I'm not sure how many of you are fluent in Latin, but our translation of that, which may not be the proper translation, is in the service of health. We are one of 8 uniformed services: Army, Air Force, Navy, Marines. National Oceanic and Atmospheric Administration is one, U.S. Coast Guard, and the new U.S. Space Force is the other one. So there are 7 others plus the U.S. Public Health Service. We have dentists in the U.S. Public Health Service, but we are joined by other public health clinicians and clinical support people, including physicians, veterinarians, nurses, therapists, physical therapists, occupational therapists, pharmacists, dietitians, engineers, environmental health officers, scientists, behavioral health people, and so forth. We're led by the nation's doctor, the U.S. Surgeon General, who is currently Vice Admiral Vivek Murthy, who is reports to the Assistant Secretary for Health, who is currently Dr. Rachel Levine. We have dental officers spread out across the nation in various agencies and departments. We have 3 departments where we currently have dental officers, including the Department of Justice, where we have dentists in the Federal Bureau of Prisons, including several in the state of Texas. We have dental officers in the Department of Homeland Security, in the U.S. Coast Guard, and I know there are Coast Guard stations in Texas along the coast, and in the Immigration and Customs Enforcement Health Service Corps, which I know there are several in Texas as well. Primarily, though, our dental officers are in the Department of Health and Human Services, in such agencies as the Centers for Medicare and Medicaid Services, which, by the way, we have a new Chief Dental Officer. You probably heard Dr. Natalia Chalmers, who is in the Office of the Administrator. So it's the highest level we've ever had a Chief Dental Officer in CMS. We also have dental officers in the National Institutes for Health, and specifically in the National Institute of Dental and Craniofacial Research. We have dental officers in the Centers for Disease Control and Prevention, in the Indian Health Service, which, as Ms. Stewart mentioned, is where I am, where my permanent job is. Also in the Health Resources and Services Administration, and in the Food and Drug Administration. I like to say that the U.S. Public Health Service is kind of the connector. We are kind of in the middle of collaborating with multiple entities. Within organized dentistry, we coordinate with and collaborate with multiple organizations, including the state dental directors and with the state and national oral health coalitions. On the regulatory side, we interact frequently with the FDA, the American Association of Dental Boards, and OSHA, and especially over the last year and a half with the pandemic. Globally, I interact with what we call the 5 Eyes colleagues, which are allies, chief dental officers in Canada, New Zealand, the UK, and Australia, with the International Dental Federation, and with the World Health Organization and the Pan American Health Organization. And then within the federal sector, we interact with the other federal dental services, the Army, Air Force, Navy, and VA, and with all of those different disciplines that I mentioned and those different agencies I'd mentioned in the previous slide. So that's it for the Public Health Service. What I'd like to switch to now are disparities in oral health. So in 2019, the CDC published a report, and this came from the National Health and Nutrition Examination Survey, and it looked at prevalence of dental disease across the lifespan. So if you look at this table on the top, you'll see different disease conditions, and just to kind of ground us all, caries prevalence is any history of dental caries. Untreated decay obviously is active disease, and total tooth loss is self-explanatory. But what you can see is across the top, those are different disease conditions across the lifespan. And when we look at differences in rates or prevalence of disease by race or ethnicity, what we see is that Black non-Hispanic Americans and Mexican Americans suffer disproportionately from dental diseases across the lifespan. And I've highlighted those disparities in red there. And in some cases, those the prevalence of disease in different races is 2 to 3 times that of white non-Hispanic Americans. With regard to income, there's also a difference. Those who are living at or below 200% of the federal poverty level, or FPL, which is around $25,000 for a family of 4, suffer disproportionately across the lifespan from dental disease compared to those who are living at or above 200% of the FPL, so the middle class. And in some cases, again, 2 to 3 times the disparity. We also, since we're talking about older adults, we also see a significant difference between the poor and non-poor. So again, using the National Health and Nutrition Examination Survey data from 2 time periods, 1988 to 1994, compared to 2009 to 2014, what we see is a big difference. So if you look at the bar graph on the left, the poor are in burgundy, red burgundy color, and the non-poor are in a grayish teal color. And what you'll see, this is looking at the percentage with a functional dentition, which we define as having 21 or more teeth. And so in that first time period of 1988 to 1994, you'll see that 16.7% of the poor had a functional dentition. And we know a functional dentition is very important to overall health, to nutrition, and so forth. And that was compared to 38.3% of non-poor people having a functional dentition. So the actual difference was around 22%, and I've highlighted that in yellow there. Now fast forward 2 decades to 2009 to 2014, and you'll see that both groups improved. The poor improved from 16.7 to 25.5. The non-poor changed from 38.3 to 67%. So both groups had pretty dramatic improvements, but the non-poor had a substantially larger improvement. And as a result, that disparity, again, the difference between the 2 groups, which I've highlighted in yellow, has actually more than doubled in the past 2 decades. So the bottom line to this graph is that the non-poor are getting healthier at a rate much faster than the poor are in older Americans. Now, these 2 bar graphs are courtesy of the American Dental Association Health Policy Institute, and it looks at access to care over two different time periods, 2005 and 6 to 2007 and to 18. And U.S. whites are in the burgundy color, Asians are in the teal color, Hispanics are in green, and U.S. blacks are in the orange color. And what you see is that on the left, if you look at access to dental care, how many people have had a dental visit in the past year in children, what you'll see is that there's not a huge difference. So you've got U.S. whites at 55.5%, and the lowest is U.S. blacks at 42.6%. So we know that the great equalizer has been children's Medicaid and the Children's Health Insurance Program. However, if we look over on the right side at access to care for adults, and again, the colors represent the same ethnic groups, what you'll see is that U.S. whites are at 47.8%, and the lowest group in this case is U.S. Hispanics at 27.8%. So that gap between U.S. whites and the lowest group is much, much bigger, about 20 percentage points. And that is because, and I'll talk more about this in a few minutes, but very few states offer comprehensive adult Medicaid dental benefits. Now, the Health Resources and Services Administration, or HRSA, designates health professional shortage areas in the areas of primary care, mental health, and oral health or dental health. And these so-called dental HPSAs, health professional shortage areas, affect about 60 million people across our country. And they are shown on this map in various shades of purple. And you can see in the state of Texas, other than the big metropolitan areas and up in the Panhandle region, most of Texas geographically is in a designated HPSA. So you can see most of West Texas and South Texas are in counties that are designated HPSAs. HRSA estimates that it would take about 11,000 oral health practitioners to go out to all of these HPSAs across the country to remove that HPSA designation. We also know when we look from state to state that there's a big difference in the density of dentists. So if we look at the number of dentists per 100,000 population, on average, there are about 61 dentists for every 100,000 people in the US, with a high from New Jersey at 81.52 dentists to a low in Arkansas, your neighbor, at 40.93. And Texas is on the low end at 51.94 dentists per 100,000 people. And when we talk about access to dental care, I'd be remiss if I didn't at least mention the social determinants of health, which I'm sure all of you are aware of. But as we think about access, if there is a parent that is struggling with poverty or job security or housing security or food security, then oral health care is not going to be one of their top priorities. And there are other factors that play into access, like oral health literacy, their patient's ability to understand treatment plans and so forth, their cultural awareness of the importance of oral health, their friends and family, how they valued oral health, and so forth. And in fact, if you look at the right, and that is courtesy of 88 HPI again, more people are willing to forego dental care because of cost than any other type of care, with almost 10% reporting in 2015 that they did not seek dental care because of the cost. And in fact, dental care has actually gone from a $60 billion industry 25 years ago to $120 billion industry today. And per capita costs have gone from $240 back in 1990 to $413 in 2018. So clearly cost is a very important factor when people are looking at their own oral health care. And for many, many Americans, oral health is still a luxury healthcare service. So let's shift gears a little bit and move away from cost, and let's talk about workforce, which really the two are interrelated, and I'll make that point in a second. So what we've seen over the last 2 decades, we saw initially we saw a decrease in dental schools, and now we've seen new dental schools again, and we've seen class enrollments get larger. We've seen a delay in retirement, and this is pre-COVID information. But what we saw from 2001 to 2018 was a 22% increase in the number of dentists in the workforce in the US. But if you look at that compared to population growth, because 22% sounds really good, but if you look at that compared to the number of dentists per 100,000 people, it's actually a lot more modest at only a 6% increase. One of the big drivers, and this is where cost is relevant, is the cost of dental education. What we see, and this is from the American Dental Education Association, the class of 2019 graduated with an average debt of almost $300,000, with 4 out of 10 having debt greater than $300,000, which equates to about $700,000 over the course of paying it back. So obviously, this is a big driver to where new graduates are going to set up shop. Many don't go back to rural America, even if they grew up in rural America, simply because of this debt burden. We've also seen, I started in private practice more than two and a half decades ago. And when I was in private practice, about 2/3 of dentists were solo practitioners. Now that has shrunk to about 1/4 of all dentists. And dental practices have kind of followed the medical model with more and more in group practices. Some of those are now in these dental support organizations or corporate dentistry, which I'm sure you're aware of. And the percentages are a little bit unknown. So the ADA estimates that 8.3% of dentists are in DSO affiliate group practices. I met with the Association of Dental Support Organizations, and they claim the number is more like 15%. So it's probably somewhere in between. So next, let me shift to some workforce models. I'm sure you're aware of these. I'm not pro or con against any workforce model, but I do want to make you aware of them. So dental therapy began in Alaska. It was brought over from New Zealand, from the New Zealand dental nurse model, and it's been largely successful by many different accounts in Alaska by therapists going to these remote villages in Alaska and being supervised indirectly, actually general supervision, by dentists in a hub clinic many, many miles away. But there is no universal model. And now that dental therapy has moved into the lower 48 states, there are various models that are out there. There are now 12 states that have authorized dental therapy. Minnesota actually, even though Alaska graduated their first therapist in 2004, and it's called the dental health aid therapist, Minnesota actually became the first state to authorize therapists in 2009. There are 9 states that are actively exploring dental therapy, and it may be more than that at this point, but Texas is not one of those, and very few of the states in the South really are considering dental therapy at this time. Another thing that we've seen, especially over the last 10 years, is an expansion of the scope of practice for dental hygienists. Now, this wheel has all the different states, and they're divided by region. And Texas is lumped in with the Southeast. And there's not really a Southwest, well, there is, but they're not lumped in there. But if you look at this, the more colors on the wheel spokes, the broader the scope of practice for dental hygienists. So what you can see from this, generally speaking, is that the Northwest, and in particular the Pacific Northwest and the Southwest west of Texas, have a broader scope of practice for dental hygienists. And the Southeast, which is including Texas, has a very narrow scope of practice compared to the other states for dental hygienists. Another model, and Ms. Stewart said that I was the expanded function dental assistant coordinator for the Indian Health Service, which I am, and we have about 1,500 dental assistants spread out across 400 programs in 37 states that have expanded functions either in restorative or periodontal. And what I mean by restorative functions is the dentist preps the tooth, removes the caries, determines the restorative material, and then leaves and moves on to the next patient while the dental assistant restores the tooth. And so there are 14 states that recognize expanded function dental assistants on the restorative side, and they are shaded in green. And again, Texas is not one of those. But those are held as a way to improve access to care or efficiency of dental clinics. Another model that was proposed and developed by the American Dental Association, partially in response to the Alaska Dental Health Aid Therapy Program, are the Community Dental Health Coordinators, or CDHCs. And just as the name implies, these are dental staff, usually dental hygienists, but also dental assistants, that help connect patients, especially the vulnerable and underserved, to dental practices, whether those are private practices or public safety net programs like community health centers. And Texas does have a fully functional community dental health coordinator in at least one place, as well as 8 other states. Now, when we talk about workforce, it's also important to talk about Medicaid participation. And what we see from our national data is that minority dentists and younger dentists and female dentists are much more likely to be participants in Medicaid compared to white dentists, male dentists, and older dentists. And this bar graph on the bottom shows the different states and the range of Medicaid participants, from a low in New Hampshire of 15.6% to a high in Iowa of 77%. And Texas is kind of right there in the middle at 57.3% of dentists being Medicaid providers. Now, I said I will not speak about, from an advocacy standpoint, about Medicaid or Medicare, but there are 74 million Americans that lack any type of dental coverage. And as of this year, only 21 states, and those are shaded in green, offer extensive or comprehensive dental benefits for adults with Medicaid. And by extensive or comprehensive, I mean more than 100 different dental procedures are covered. Texas, according to the data I have, still offers emergency coverage only for adult Medicaid patients. Now, I said that I would close out by talking about integration of care, and I want to spend a little bit of time on this. So what I'd like you to do is look at these numbers because these are important numbers. When we talk about integrated care, what is the goal that we're talking about? And from a broad perspective, it is that all Americans should have access to high quality, culturally competent, and that's important, oral health literate, affordable healthcare in a location that's convenient to them and their families. And we are a long ways from achieving that, as you know. Data that was just released from the Agency for Healthcare Research and Quality, or AHRQ, shows that in 2018, there were 112.3 million Americans who saw a medical provider, but not a dental provider. Now, just let that sink in for a minute. So 112 million Americans saw a physician, but not a dentist. So what does that mean as far as integration? It means that there's a great opportunity for medical providers across this country to impact their patients' oral health in many different ways, from doing basic oral health education, explaining the importance of oral health as it relates to overall health, doing oral health screenings, applying fluoride varnish, and there's even some best practices in Wisconsin and Minnesota of physicians doing silver diamine fluoride to help arrest decay. So it draws me back to something a former Surgeon General, C. Everett Koop, who many of you may know was Surgeon General back in the early 80s during the AIDS epidemic and so forth. He said, you're not healthy without good oral health. And so that is a message that we need to keep impressing upon our medical colleagues. And so where does that start? How do we make that connection? Well, integration starts at the local level. So if you're a dental provider or in the oral health realm at all, reaching out to medical professionals, behavioral health professionals, et cetera, happens at the local level. The ADA, the U.S. Public Health Service, everyone else can talk about integrated care, but unless those connections are made locally, integrated care will never happen. A second number I want you to look at is 28.2. That's 28.2 million Americans that see a dental provider each year, but not a medical provider. So remember at the very beginning, I said that integrated care is multi-directional, and it really is. So again, we're healthcare professionals first. So there's an opportunity, and I'll show you some more slides in a minute, but there's a great opportunity for oral health providers to impact their patients' overall health in many different ways, such as doing screenings for hypertension, diabetes, obesity, high cholesterol, substance use disorder, domestic violence, depression, and such many other things as well. There are numerous examples across this country of oral health professionals actually being the sentries, the first people to find a chronic disease condition in a patient. Two other numbers I think that are important are 7.0 and 1.1 million. There are 7 million children and adolescents under the ages 6 to 17 who see a dental provider each year, but not a medical provider. And 1.1 million children under the age of 6 that see a dental provider, but not a medical provider. So think about this, especially the under 6 for a minute. These are children that may have fallen off vaccination schedules and so forth. So there's a great opportunity to educate, to make referrals for those children. Think about the 6 to 17-year-olds. We'll talk about HPV in a few minutes, but there's an excellent opportunity to talk about HPV vaccination, tobacco cessation, substance use disorders and prevention, and so forth. So we'll get into all of that. I want to show you this. It is estimated that there are 11 million Americans that have undiagnosed hypertension. So I know many of you do blood pressures before oral surgery or before any complex surgery. I think it is of great value for oral health providers to do a hypertension screening on every patient at the exam appointment and perhaps routinely at follow-up appointments. There are 7.3 million Americans that have undiagnosed diabetes. Again, an opportunity to screen. Many millions with high cholesterol, 10 million with depression. Now, we don't often think of dentists or oral health providers doing depression screening, but there are many, many great examples, best practices of dental providers doing just that. And it's really a simple tool. It's not a diagnostic tool to do a screening. And then substance use disorder, obviously, especially in the last decade, this has risen to great prominence. And so I think there's a place for oral health providers there as well. I mentioned HPV. So if we were in a crowded room, I'd ask for a show of hands if you thought the most prominent or most common type of HPV attributed cancer was cervical cancer. And many of you might raise your hand and say yes. But in fact, about 3 years ago, HPV attributed oropharyngeal cancers surpassed cervical cancer as the top HPV cancer, with about 14,000 cases per year, the majority of which are in men. So there's a great opportunity for oral health providers to make an impact, because this is in our world, oropharyngeal cancers. So we should be having a conversation in the very least. And, some states are starting to move, like Oregon, toward dentists being able to do HPV vaccinations. But we're in a position where we can at least educate parents and teenagers about the HPV vaccination. There is one, Gardasil 9, which vaccinates against 9 variants of the human papillomavirus, and it can be given from ages 9 all the way up to 45. So it is appropriate, even in adult patients, to ask on a medical history form, have you had an HPV vaccination? And if it's an adult and they say no, there's an opportunity to educate them and make a referral, in the very least, to a medical provider whom you've already established a connection with to get that HPV vaccination. The ideal time, of course, for HPV vaccine is ages 11 and 12. Some other information, 55% of adults do not get the annual influenza vaccination, and we're coming up on flu season right now. And I know that there were very few influenza cases this past year because, another virus was much more prominent. But I would suggest that you recommend to every single patient that comes to your practice in the next month or two, next 3 months, to get vaccinated for influenza. And yes, it's true that the influenza vaccine is not 100% effective, but it is also true that those with a vaccination, if they do get one of the different types of influenza, it's usually a much milder case. There are also 31% of older adults over 65 that have never had a pneumococcal vaccination. So you should be querying all of those over 65 and ask them and make that warm referral to a medical provider. 19% of children, and this is really important, 19% of kids under 2 years of age have not received their full complement of DTP or DTaps, and 9% haven't received their MMR. So again, in the future, dentists may be able to actually give the vaccination like they are able to in Oregon, but in the very least, you should be able to ask parents if their children are on schedule for vaccinations, and if they're not, make that referral, because again, you play a very important role in that regard. Economists say that the annual economic impact of screening for diseases could could save a substantial amount of money. The economic impact of these chronic diseases is more than $1 trillion today. It could be more than $6 trillion. And screening could save $102.6 million, or about $33 per patient, if those screenings are done in dental offices. So as we move forward, when we talk about integrated care and all these different things, coverage of adult dental Medicaid, Medicare, these different workforce models, value-based incentive payments, and so forth, are we going to continue to kind of do it alone, or are we going to work with our medical counterparts? And that is a reason for making those, building those relationships with medical, pharmacy, behavioral health providers, social support providers, and so forth. Now, many of you have heard of the U.S. Preventive Services Task Force, and here are a few things from that task force. They recommend screening for hypertension. There's strong evidence to support screening every adult over the age of 18 for hypertension. And again, remember, 28.2 million Americans see a dentist, but not a medical provider. So that's 28.2 million Americans you could have an impact by doing hypertension screenings. For those 40 to 70, screening for abnormal blood glucose levels, either with a glucometer, doing a fasting blood sugar, or doing point of care HbA1c testing, is also recommended by the U.S. Preventive Services Task Force. Screening for substance use disorder is also a recommendation by the U.S. Preventive Services Task Force, as well as screening for depression in both adults and in adolescents. So again, dental providers can do this, and a screening, as you know, is not a diagnosis. So screening a patient and making a referral to a primary care provider or a behavioral health provider is to further screen and do a diagnosis is the proper course of action. A friend of mine who is also the ADA president this year, and he's from Arizona, is Dan Clemenson. And this is what Dr. Clemenson said about screening. He said it's well within the scope of practice to screen not just for COVID, but also all of these other things like glucose levels, blood pressure, and so forth. Patients with abnormal test results would be referred to a physician or other qualified health medical professional. So again, for any of you that are savvy, you can see that there are a few problems with this. You should do blood pressure against skin, not over clothing, and the arm should be more elevated than this as well. The picture on the left is a clinic, a community health center in West Virginia, which is kind of ground zero for the opioid epidemic. And that's a dentist doing a substance use disorder screening. So it's not just asking the question on a medical history, it's following up by verbally having that conversation with patients. Picture on the left is a clinic in Kansas where a nurse is actually in a dental practice doing did a finger stick and checking for diabetes. And the picture on the right is actually a clinic in Texas, in Dallas, that is affiliated, I believe, with Texas A&M, where a student not just asks the patient to list their medications, but actually to bring in the medications. So then the student can look and give, explain to the patient the different interactions and what those medicines are for, not assuming that that patient remembers what their other healthcare providers or pharmacists may have told them. Now, I want to do a deeper dive into integrated care by giving a personal example. And as Ms. Stewart mentioned, I work for the Indian Health Service, and one of my roles is I'm the Oral Health Promotion Disease Prevention Consultant, which is a real fancy term for National Prevention Consultant. But back in 2009, we began in the Indian Health Service, and again, we have 400 clinics spread out across 37 states, including several in the state of Texas. But we began this initiative called the Early Childhood Caries Collaborative. And the reason we did this is that early childhood caries is very prevalent in American Indians and Alaska Natives, with 4 times the prevalence of US whites and twice that of the next highest minority group, which is US Hispanics. But the very first thing we did was we defined early childhood caries, which, by the way, is actually defined as the presence of any decayed, missing, due to decay, or filled teeth in a child under 6 years of age. We define this as a medical problem, not a dental problem. And that's really important because there are sufficient resources, research that shows that early childhood caries causes myriad health problems, including poor nutrition, pain and infection, low self-esteem, even poor success once they go into school later in life. So there's a lot of reasons that early childhood caries should be tackled as a health problem and not just a dental problem. So what we did was we reached out. What we found with American Indians and Alaska Natives is that by age 2, 40% of children already had early childhood caries. So you're not talking about preventing disease at that point, you're talking about treatment. So we want to reach out and get these children to access dental care before the age of 2. And we actually had a motto that 2 is too late. And so who sees children under the age of 2? You know, we still, just a couple years ago, we still had pediatricians saying, don't take your kids to the dentist until age 2 or 3. And again, 2 in our population, 2 is too late. So we had to dispel that myth, first of all. And so we had to educate medical providers. We reached out to public health nurses. So we know that public health nurses go into the early Head Starts and daycares and examine children. We reached out to the WIC program, the Women, Infants, and Children's program. And we actually had some cases on reservations where tribal councils passed resolutions to say mothers and children could not get WIC benefits unless they had a dental exam, so a policy change. We also had to reach out in tribal culture and explain to tribal councils and elders why early childhood caries is important, because we know that baby teeth are important in many ways. They kind of set the foundation for good oral health when the permanent teeth come in. And then, of course, we reached out to daycares and Head Starts as well. So our goals were to increase access to care for 1 to 5-year-old American Indian Alaska Native children, specifically for 1 to 2-year-olds. But we also want to promote dental sealants. Many general dentists in our system, simply they'd see a child with a lot of decay, they'd automatically write a referral to a pediatric dentist. And in some cases, those appointments were 6 months away. So what might have been a small occlusal lesion ended up being an extraction 6 months down the road. So we want to promote dental sealants to prevent caries, including glass ionomer sealants. So this started back in 2009. So we were a good 7 years ahead of the American Dental Association and the American Academy of Pediatric Dentistry in their policy statements supporting sealants on primary molars. We also want to increase the number of interim therapeutic restorations, or ITRs, which are glass ionomers, to help prevent further deterioration of teeth by doing atraumatic restorations. And finally, fluoride varnish 3 to 4 times a year on every American Indian Alaska Native child. And so we had about 3/4 of our 400 programs participate in this. And as a result of that, and I'll show you the results in just a second, we had a 22% increase in access to care from 2009 to 2017, which is a huge increase. But this is what's important: 14% of that increase came from referrals outside of the health system completely. So not from medical providers, but from early Head Starts, daycares, and tribal leaders and so forth. Dental sealants in our system increased from 48% or by 48% in 1 to 5-year-olds. And this was a huge paradigm shift, getting general dentists to actually treat these children and to do glass ionomer sealants, especially on primary molars. We had interim therapeutic restorations increased by 200%, and fluoride varnish increased by 115%. Interesting about fluoride varnish, that's something we taught medical providers to do, and we had a 300% increase in the number of fluoride varnish applications done just by medical providers. So some significant improvements. As a result of that, we had in our population, American Indians and Alaska Natives, the first ever in the history of the Indian Health Service, measurable, statistically significant decrease in both early childhood caries prevalence and untreated decay over that 8-year period, with a 5% reduction in prevalence, which is any history of decay, and a 14% reduction in untreated decay. So, and again, you could see the numbers that I referenced earlier about the percentage increases in each of our goals to the right of this. So hopefully I've taught you something about medical dental integration, which we should change the name because it is multi-directional now. So I hope you've enjoyed this presentation where I've given you an overview of the U.S. Public Health Service, which reminds me, if any of you are interested in the U.S. Public Health Service, you can go to usphs.gov, which is at the bottom of this slide, to learn more about it, including we have a new National Guard type component called the Ready Reserve Corps. So that's an opportunity for you as well. But I've talked about the U.S. Public Health Service. I've talked about inequities and disparities in our system, in oral health across this country. I've spoken to you about the cost of dental care and access to care issues, workforce issues, and I've closed out with talking about multi-directional integration of care. So I hope you've enjoyed this. I look forward to any and all questions that you may have. And Ms. Stewart, I'm 5 minutes ahead of time.
Oh, and that was good. You know, your IHS data, the reductions there is really, truly impressive. Congratulations.
Thank you.
That's super work. We do have some time. So if anyone from Houston wants to ask some questions, you can unmute yourselves or type it into the chat box. And I want to apologize to everyone for I was gliding my mouse over the buttons at the bottom to check the chat box, and it went over record. And so I'm sorry for the interruption about that. So let me check the chat box right quick and see if there's any questions. And again, you can unmute yourself to ask if you'd like.
Can you hear me?
Yes.
Hi. So, I was glad you was talking about the other vaccines that you could, because we're actually beginning to do that now in the Houston Health Department, even in our dental clinics, as part of the kind of COVID screening. We have a little piece of paper that we give to the clients. So we not only check or ask about if they have been vaccinated, it's all self-report. And if they have not been, would they like information? But on top of that, they've actually added the very thing, Tim, that you have been talking about, is it gives us the opportunity to ask the parents, because we see a lot of children in our dental clinics, to ask about their own vaccination, if the type of immunization, and then we give them actually flyers directing them to places where they could get free immunizations for their children. So I was so glad when I saw that. I said, yay, we're already doing this.
Well, yeah, that's very good, very good. And I would say that, COVID has given us a wonderful opportunity. I mean, COVID has been devastating. We know that. And, many people have died, many people have been infected, many people have been hospitalized. But behind all that, what we have seen is that there's been more of a willingness to include the oral health team as vaccinators. And, prior to March, from December to early March, I believe 24 states had authorized dentists either through a state board regulation or an executive order from the governor or through some kind of other temporary measure allowing dentists to vaccinate. And I believe 18 states had allowed dental hygienists to vaccinate. But in addition to that, there were 8 states that authorized dentists to do flu vaccinations, which I thought was really a big step. But of course, the game changer occurred. I may have the date wrong. I think it was March 11th. But the 7th Amendment to the Public Readiness and Emergency Preparedness Act, or PrEP Act, authorized every dentist across the U.S. to vaccinate. So every dentist, regardless, because federal law supersedes anything at the state level, every dentist can vaccinate. And it actually gave liability protection and everything. So I hope that if you're not vaccinated, if you're a dentist and you're not vaccinating, you're at least making referrals, educating patients. It's almost, I think the way to do this, sorry to sort of jump down this rabbit hole on vaccination, but the way to talk to patients is just like we do about tobacco. To use the 5 A's, to ask them if they've been vaccinated, to advise them that they should get vaccinated and give them the proof, the facts from CDC. Don't fall into the whole misinformation campaign. And then, assess their willingness to get a vaccine. That's the 3rd A. And if they're willing to do it or willing to get more information, then you go to either arrange for a follow-up with their medical provider or I forgot the 5th A, either arrange or whatever, either arrange for them or do it yourself, do the vaccination. So certainly there's a place for us, but I'm glad you mentioned vaccinations.